afternoon, everybody. This is Amy from Intermountain Healthcare. It looks like we're at the top of the hour, so we'll go ahead and get started. Today we have a really exciting webinar for you about reducing CLABSI. First, a couple of just quick announcements. Excuse me. Now that the holidays are over and we're all back in the grind, we're starting up our affinity calls again, with the first of the year starting tomorrow. We have the readmissions affinity call tomorrow, and then as you can see on the slides, we've got a few more coming up in the next couple of weeks. On the henlearner.org calendar, you can find the details and call-in information for all of these, and you can expect some updates and some prompting questions sent out to you this week through your email as well. So take a look at those. We're excited to start these again. The affinity calls have been a big success for us, and we're excited to get them rolling again for the new year. Excuse me. At this point, I'm going to turn the webinar presentation over to our presenters and let them introduce themselves. Dr. Loftus, I'll hand it over to you. Just a moment.
Hi, everyone. I'm Dr. Loftus. I'm an anesthesiologist in critical care attending here at Dartmouth-Hitchcock Medical Center.
Hi, I'm Matthew Koff. I'm also assistant professor here at Dartmouth-Hitchcock, working in anesthesia and critical care as well. Happy to be here today.
Can everyone hear us?
Yes.
Okay. So we're happy to talk about this exciting subject. And this talk is really meant to serve as everyone knows, as an overview for sexual line-associated bloodstream infection, or CLABSI prevention, across a wide variety of settings, with the overall focus really applicable to a number of different hospitals, those at various stages of development, those who are just beginning, and as we'll see as a general theme throughout the talk, hospitals that really are ahead of the curve, and we have examples of hospitals that fit each and every one of those descriptions.
Can everyone see our talk? We're having trouble seeing our talk up on the screen.
If you can go ahead and share your slides, that will make them show up. If not, we can go back to being the presenter, Randy. Would you like us to do that?
Let's see. Hold on a sec. We'll share. Let's see. We're trying to share our slides right now. Can you guys go ahead? I think we kind of got in that loop like the last time we had trouble sharing our slides.
Sure, no problem. We'll go right back to it. Just one moment, please.
It says it's loading, but.
Randy, if you can share, if you can move the globe back to Jason Scott, that will give us presentation rights again.
Okay.
Thank you, and sorry for the difficulty. We appreciate your patience.
Oh, no problem. I think we may be, let's see what happens here. There we go.
Okay. Everyone see him now?
Can you see the slides now?
No, now we're presenters, so.
All right,
okay.
We'll go ahead and present on this side. Just call for your slides.
Go to slide 9 with the objectives, please. Actually, it's 7 on yours. That's where we want. Okay. So our overall goals for today are fairly simplistic. We really want to understand the importance of CLABSI in the current healthcare environment. And what we mean by that is, how has CLABSI prevention changed, especially since 2006, since the early work of Peter Pronovost? And based on that, what is the future for CLABSI prevention? What have we learned in the interim, and how can we use that to guide us as we move forward today? And the second is, we really want to delineate, or we intend to delineate metrics for performance improvement. So our goal is to help everyone understand how to best measure performance in CLABSI reduction, both initially at baseline and then over time. And then we'd like to provide some insight into how to develop intervention strategies to reduce CLABSI. So for every hospital on that continuum that I described, from getting started to working harder to being ahead of the curve, wherever you might be, we'd like to map out, our goal is to map out some evidence-based interventions that will ultimately lead to improvements at your hospital site. And finally, we'd like to share some insight into how to identify and access resources at each of these sites so that you can start or extend a CLABSI reduction program. Next slide, please. So, as we all know, healthcare-associated infections are a tremendous problem. They affect up to 1.7 million patients per year with infections and are associated with approximately 99,000 deaths annually. So it's not surprising that they're considered one of the top 10 causes of death in the United States. And in fact, in 2001, CLABSI was reported as the 8th leading cause of death. There are a number of different healthcare-associated infections. CLABSI is only one subset, but it's considered of those to be in the top 4, occurring at a rate of 0.7 to 7 infections per 1,000 line days. Now, each of these infections has a striking attributable mortality rate of 12 to 25%, which really amounts to approximately 11 deaths daily. In addition to that, we have to consider the economic burden that we're dealing with each infection costing approximately anywhere from $9,000 to $40,000, but up to $40,000 per infection. And that amasses to an estimated cost in the literature of approximately $9 billion annually. Next slide. So we need to consider, before we get into this, why has CLABSI remained a focus despite this early work by Peter Pronovost that seemed rather definitive in terms of how to prevent these infections. So how can we explain the timely nature of this discussion? And this is an important question because some might believe that all the work for CLABSI prevention has already been done. And this may be a faulty perception for a number of reasons. First of all, the goal of this initiative is to encourage improvements in infection control across a wide variety of hospitals. So hospitals that may or may not have had the capacity or the resources, such as those in the early Keystone project by Pronovost, to actually execute the preventive measures that he described. And our goal is to help facilitate that process. And the second reason is that the overall body of evidence, as we'll discuss, suggests that as a whole across the United States, we haven't solved this problem. This problem really isn't that well understood. We're not at zero infections, as the literature has suggested in the past. So I'd like to begin to explain the timely nature by discussing the work by Peter Pronovost. So back in 2006, Dr. Pronovost published his early work with the Keystone project in the New England Journal of Medicine. And this work involved 103 intensive care units, all of which actually resided in the state of Michigan. And he implemented a quality improvement project that focused on some key evidence-based measures for CLABSI prevention. And what he did is he combined some systems-based approaches, utilizing line cards and checklists, with some evidence-based educational initiatives, such as feedback and daily assessment of the need for lines, in sort of a bundle. And he encouraged dissemination of this quality improvement strategy, trying to create a culture of patient safety early on. And the primary outcome of his work was the incidence of central line associated infections defined by the number of infections per 1,000 line days. And he found a striking impact of these interventions with a 66% decrease over an 18-month period. Now, he reported a median rate of 0. His median, however, was not 0, but it was still striking that they were able to generate such a reduction in infections over a short period of time with some simple preventive measures. Now, this early work by Peter Pronovost was later supported by a couple of statewide experiences, such as those in Rhode Island, reported by DiPaolo et al. In 2010, and an experience in Hawaii, reported by Lin et al. In the American Journal of Quality in 2012. So this body of evidence is well substantiated. And this high level of evidence has resulted in a generalized belief by stakeholders that achieving these zero infection rate is actually a reasonable goal. This is suggested by the response of the Joint Commission in January 2010, where as part of their national safety patient goals for that year, they initiated a new requirement for hospital-wide reporting of CLABSI. And that was in parallel with CMS making some changes in January 2010, where they required participating hospitals to report to the National Healthcare Safety Network. So this problem, this widespread public health concern, has gained the attention of national stakeholders. So given the morbidity and mortality that it causes, the widespread public concern and the attention of stakeholders, this is a problem that all healthcare professionals need to pay attention to. And because we're not at zero yet, this is something we need to pay attention to today. Now, next slide, please. Okay. Now, this is also highlighted by the fact that CMS in August of 2010 decided that they would no longer reimburse for central line associated infections. And this stance is further substantiated by work put forth by the National Healthcare Safety Network in 2011, where they compared CLABSI rates in 2009 to CLABSI rates in 2001, and ultimately they found that there was a 58% decrease in these rates. And furthermore, when they compared the rates in 2010, they found a 32% further decrease. So it's not surprising then that reporting to the National Healthcare Safety Network is now considered mandatory by 28 states. And I already mentioned the fact that they're no longer reimbursing, so this problem is gaining more and more attention. Yeah, next slide, please. So many hospitals, perhaps all hospitals in the future, are going to be held accountable to a very high degree. We have the attention, this problem has the attention of the Joint Commission with hospital-wide reporting of CLABSI. It has the attention of CMS with mandatory reporting for those who are involved in the program and no longer reimbursing for CLABSI. And we're also having now the requirement for multiple states, there's mandatory reporting. So this is a trend that may be problematic from any angle, from the patient morbidity and mortality aspects to the economic burden that each hospital is now faced with. And this is a problem that we need to be aware of and begin to solve more effectively. So to summarize, I'd like to review that we have this problem is a national public safety, public health concern. It's associated with significant morbidity and mortality, significant burden. This is burden that we will assume, and this is a burden that stakeholders believe we should bear. So the question is, actually the fact is we are not at zero yet. There is no question. The medians of the data are misleading. We've already discussed the data from Rhode Island and Hawaii. They reported median rates, but their actual means were 0.97 and 0.6 per 1,000 line days respectively. And that's the best evidence that currently exists. The fact is we are not at zero, and there's a lot more work to do. So can I have the next slide? So the obvious next step in this discussion is to identify defects in our current preventive measures, and then to discuss how we may improve upon them. But before I do that, I'd like to discuss this recent article titled The Effect of Non-Payment for Preventable Infections in the United States Hospitals. This was a study that involved 398 National Healthcare Safety Network hospitals, and it was published in the New England Journal of Medicine in October of 2012 by Lee et al. And what they did is they evaluated the effect in a quasi-experimental study designed to evaluate the efficacy of non-payment on the primary outcomes of the incidence of CLABSI, or catheter-associated urinary tract infections, and CLABSI. And they used ventilator-associated pneumonias as a control. And what they found in these 398 hospitals is that the act of non-payment had no impact on the overall infection rate. Now, there's a general theme that I believe is suggested here, and we're going to repeat this throughout the presentation, but we don't believe that this means that the non-payment approach is incorrect. We believe that this suggests that there may be a great void and taking evidence to the next step, which is to a change in practice. And that's one of the major objectives of this talk, is to describe how you might take the best evidence and ultimately generate that changes based on that knowledge. Next slide, please. So why are we not at zero infections? What's going on and why? Well, there are a couple of issues at hand. The evidence put forth by McLaws et al. In Critical Care Medicine in 2012 says that while we're handling infections due to insertion very well based on interventions that are designed on the early work or supported by the early work of Pronovost, we see most of our infections are remaining persistent beyond 7 days of insertion. So we have a maintenance problem. That's a major area for improvement, a major deficit that we've identified. In addition, another deficit is that these infections are occurring in other hospital arenas, such as operating rooms, hospital wards, and outpatient settings. And this premise is supported by Kelly et al. And Guz et al. Published in the Infection Control and Hospital Epidemiology in 2011. Next slide, please. In fact, before we talk about this next slide, I wanted to state that we could even look at this issue in a manner that's a bit more broad, and perhaps we should, because CLABSI is really a subset of all intravascular device-related infections, or BSIs. And BSIs outside of CLABSI are also associated with a significant increase in patient morbidity and mortality. They're associated with economic burden, increased hospital costs, and they're associated with both central and peripheral intravenous catheters. And interestingly, they occur at a very similar rate to peripheral infections of 1 to 3 per 1,000 infections, and currently at many hospitals you're seeing central line infection rates at 1 to 3 per 1,000 line days. So similar rates, similar outcomes. And as you'll see, we conducted a site visit at Denver Health, and we had an interesting discussion there about the impact of peripheral intravenous catheters based on central, and we found that there are a number of occurrences that are associated with devastating outcomes related to peripheral IV contamination occurring in many hospitals. So we need to think about this problem as broadly as we can as we approach the next steps towards preventing it. Next slide, please. So the first step in solving the problem is to define what CLABSI is. And CLABSI is defined by the number of infections per 1,000 line days. And so what we're looking at is you can go to in order to get an accurate description of the definition, you can actually go to the website listed here. And what we have is that CLABSI it can either be laboratory confirmed with a positive blood culture and in-line use within 48 hours, or it can be defined by the diagnosis of clinical sepsis without laboratory evidence, as long as the central line wasn't used during the prior 48-hour period of infection. We also need to think about, according to these definitions, is how do we define a central line? Well, it's a vascular access device that terminates at or close to the heart or in one of the great vessels. And interestingly, that does include the brachiocephalic veins, which could include a variety of catheters, and certainly includes PICC lines, mid-position catheters, as well as rapid infusion catheters such as RICs. We also need to think of central line days. So it's important that as we move forward with this initiative, that we approach this systematically. And that is, a central line day is considered any day that a patient has a central line in place. So if a patient has multiple lines in place, that patient would be considered to have one line, not several lines, because if you consider them to have several lines, that may artificially reduce the incidence of the CLABSI infection rate. Next slide, please. We also want to make sure that we're defining these as CLABSI and not catheter-related bloodstream infections. These are a bit different because CRBSIs are infections where you have positive blood cultures that and where the causative organism of infection in the blood actually matches a blood culture from the tip of the catheter, or the blood culture drawn from the central line actually becomes positive at least 2 hours sooner than a culture drawn from the peripheral blood culture. from the peripheral blood. So while that's an important subset of definitions of line infections, that's not the focus of this discussion. Our focus is on CLABSI, which is an association not confirmed as I just described. We also need to consider the pathophysiology of CLABSI in this. So it occurs by two major mechanisms, an extraluminal route, which typically explains those infections due to insertion, and an intraluminal route, which typically explains those infections due to maintenance, which would include managing the injection site, the hub, the fluid column, and also access, how you handle the devices. Next slide, please. The risk factors, there are a number of risk factors for central line associated bloodstream infections, and they do match the underlying pathophysiology. So we need to consider colonization of the catheter or the insertion site or the injection hub with organisms derived from the provider hands, patient skin surfaces, environmental contamination, even including equipment. And it's not surprising then that the duration of catheterization is a risk factor for these, with greater than 7 days increasing the number of opportunities for exposure to these reservoirs during access or insertion practices. Inexperience and knowledge of personnel are clearly important factors because they're associated with poor aseptic practice. They're associated with they're associated with nurse and patient ratios. And we also need to consider the fact that provider education and certification for proper technique are very important in terms of risk factors and prevention of these outcomes. We also need to consider that intravascular catheter design and handling, such as positive pressure displacement valves, are important factors in the development of these infectious processes. In fact, there is some evidence that disinfectable needleless closed catheter devices may increase the risk of CLABSI in various environments following their implementation. Next slide, please. Additional risk factors, of course, include the site of insertion. There's level 1A evidence to suggest that the femoral vein is less optimal as compared to the subclavian vein in the internal jugular. Did I say that right? Yes. So femoral vein insertion sites should be avoided. Multiple lumen catheters increase the risk due to more manipulation and contamination in multiple ports. Again, there's greater chance for exposure to the same reservoirs. Increased tissue trauma during insertion is another risk factor. That's because that compromises our primary defense against the introduction of infectious organisms with this intact skin barrier. And then TPN and heparin and potentially lipids are problematic because heparin enhances or causes biofilm formation, whereas TPN and lipids can cause precipitations that ultimately lead to blood clots, which then can lead to increased risk of infection. High patient-to-nurse ratios, as I mentioned, and then if the patient's infected elsewhere, they become colonized, and that increases the risk of infection as well. So all factors we need to consider. Next slide, please. So now that we understand what the definitions are, what the underlying pathophysiology is, and what the evidence suggests about the risk factors for these infections, we need to consider what we can do to actually improve our preventive measures and our action in this area. So one of the first things to consider is education. There's level 1A evidence for education within the literature, as we found. It's one of the most evidence-based areas. And you can approach education by using a number of different techniques, including staff in-service lectures, including certainly periodic updates and reassessment. And really what you should do is review the literature at whatever level you're at, getting started, working harder ahead of the curve, and identify the most cost-effective evidence-based measures, which we're going to highlight today, individually and combined. And incorporate those into fact sheets so that you can educate your nursing and physician staff. And in fact, there's a fact sheet that is contained in the toolkit that's at the end of this discussion that would facilitate that process. And then this can lead to a credentialing and a certification process. Now, you can take this early on, take this generalized approach, and then you can narrow it into a more specific approach targeting specific factors such as ultrasound-guided insertion, which is an evidence-based practice that has been shown to reduce the complications associated with line insertion and infection rates. The IHI bundle is really the basis of the early Keystone project, and there's level 1A evidence to support the bundle, but many of the components of the bundle are in and of themselves level 1B evidence. For example, hand hygiene. This is considered the #1 preventive measure by the CDC, yet we lack level 1A evidence for efficacy. But the evidence for hand hygiene can be best summarized by the WHO Guidelines on Hand Hygiene published in 2005, and/or the Guideline for Hand Hygiene in the healthcare setting published by Boyce et al. In 2002. Another intervention to consider is our full barrier precautions with barrier to the patient, with patient-provider gown, hat, gloves, and mask. And the evidence for this is actually level 1A because it comes from work published by Rad et al. In Infection Control and Hospital Epidemiology in 1994, where they found that the use of full barrier precautions was actually associated in an RCT with a 6-fold decrease in the incidence of central line-associated bloodstream infections. So very well evidence-based. Chlorhexidine skin antisepsis is also well ingrained in literature. It is definitely, there's level 1A evidence for that. The early work for that is based on the work of Mackey et al. Published in the Lancet in 1991, where they conducted a prospective randomized controlled clinical trial comparing chlorhexidine to alcohol or povidone iodine. And then it was supported by later work in a meta-analysis published in the Annals of Internal Medicine in 2002, where chlorhexidine was found to be superior. So that's clear. Chlorhexidine is the agent of choice as compared to the other two. And we need to avoid the femoral insertion site as I described, and also based on Pronovost work, do a daily review of lines with prompt removal if they're unnecessary. Next slide, please. This evidence supporting the use of chlorhexidine is well ingrained within the literature as I described. Just want to highlight in this meta-analysis published in 2002, shown here that, as you can see, it's in most of these studies, there are 7 studies here, 4 out of 7, it was very effective, but the risk ratio is shown in the diamond below to be 50%. So there's a 50% decrease in the risk of infection development if you use chlorhexidine. And I think this might explain this later work recently where they actually looked at the femoral insertion site and found that, as in contrast to earlier work, that there was no difference in the infection rates between the femoral insertion site, subclavian, and jugular veins. But the fact is that interventions such as use of chlorhexidine antisepsis may actually decrease the ability to find an effect of these interventions. It doesn't negate the effect of insertion site choice, but what it's saying is that these interventions, highly effective interventions, are reducing the bacterial burden and making the effect size much smaller to see. Next slide, please. We also need to consider interventions such as the venous access team. Now, this intervention is not well ingrained within the literature. There are a couple of studies that highlight the efficacy, but it's only in prevention of peripheral venous catheter complications with intravenous therapy teams. This is level 1A evidence, and is evidenced by a randomized controlled clinical trial published by Neil Seufer et al. In the Archives of Internal Medicine in 1998, where they found that the introduction of where they compared IV insertion under controlled conditions to those with an insertion team and found a dramatic reduction in the number of complications, serious complications such as bloodstream infections in the treatment group as compared to control. So while there's evidence in the peripheral IVs, it's a stretch to bring it to central lines, but it does make sense from a pathophysiological standpoint. Now it's important to it suggests that it's important to educate, train, and observe. There is level 1A evidence for that, and periodic updates and reassessment are also part of that process. Next slide, please. So the next step in the process was to take each of these individual evidence-based measures and combine them in enhanced systems-based approaches, and that's what I said earlier is what Pronovost did, and probably that's likely the cause or the underlying etiology of his success, so to speak. But in this study that I've already described, he basically added feedback, education, and removal of unnecessary lines to each of those earlier evidence-based interventions that we just discussed. And early on in 2005, he was already working on the cusp where he was trying to create a comprehensive unit-based safety program. And he developed that program over the last several years, and it has been found to be very efficacious. So that's what we want to talk about next. So if we could transition to the next slide. But before we do that, as I mentioned earlier, he has this early work, this Keystone work was supported by an extensive body of evidence later on, such as by DiPaolo, Lynn, and McLaws. Next slide.
You able to, yeah.
Next slide, please.
One more slide, please.
So the overall goal of this comprehensive unit-based safety program that he initiated in 2005 was to educate staff on the science of safety, identify defects within the culture, then assign an executive to adopt the unit, and then learn from one defect per quarter and implement teamwork tools in order to execute change. Next slide, please. Now, the overall goal of this was to work to eliminate line infections below a rate of a state mean of less than 1 per 1,000 catheter days, or to a target median rate of 0, to improve the overall culture of patient safety, and to learn from these defects. Next slide, please. The idea behind the initial CUSP training was to learn, as I said, from the defects that they found within their own hospital arena, so they could ultimately translate this evidence that they derived into practice, and that was the next component of his work called TRIP. The goal was to summarize the evidence in a checklist, identify local barriers to implementation, measure the performance, and then ensure that all patients get the evidence. Next slide, please. This is just a slide showing the pathways for that. And due to limitations in time, I'm going to hold off on discussing it, but it describes what I just said. Next slide, please. This early work by Pronovost looking at the CUSP and the TRIP started in 2005, but he ultimately demonstrated evidence and published it in 2008, and then because what he did is he implemented it early on and then demonstrated that the effect could be sustained for 2 years beyond the initial period started in 2006. And this is just a slide showing that the impact of this intervention was maintained over a 2-year period. Next slide, please. Okay, next slide. So then the next step after demonstrating the efficacy of the initial Keystone project, followed by the CUSP, followed by implementation of the TRIP, was to actually disseminate this across the United States in a large quality improvement initiative. And what they did in 2009 is that they partnered with the CDC to support these measurements and timely feedback of CLABSI and HCAIs, and for state hospital associations to partner with state-based organizations to address the elimination of these infections. Next slide. And what they found is that when they compared the infections in 2009 to earlier infections, they found that there was initially a 58% decrease, and then they compared in 2009, and then they compared the rates in 2010, and they found an additional 33% risk reduction. And furthermore, the number of units with 0 CLABSIs per quarter increased from 27 to 69.5%. So these environments designed to improve the culture of patient safety were highly efficacious. So, and another finding here is that this on-the-cusp stop BSI demonstrated that even for hospitals that have already achieved low infection rates, further improvement is something that could be achieved. Next slide, please. We also need to consider post-insertion improvement measures, and they're based on the same pathophysiology, extraluminal versus intraluminal routes. And the chlorhexidine-impregnated sponges are well described in literature as highly efficacious. This can be best supported by the work by Timsit et al. Published in JAMA 2009. The authors conducted a 2x2 factorial randomized controlled clinical trial over a 2-year period from 2006 to 2008. They looked at 7 intensive care units. 3 of these were university-based, 2 were based in general hospitals in France. All of them were in France. And the primary outcome was the incidence of central line-associated bloodstream infections. And the secondary outcome was the overall incidence of colonization, trying to identify in a equivalent study whether or not the frequency of dressing changes had an impact on the incidence of colonization. They ultimately evaluated 1,636 patients and over 28,931 catheter days. And they found that the rate of CLABSI was reduced from 1.3 per 1,000 in the control group to 0.4 in the treatment group. They also found no increase in colonization with increasing dressing changes from 3 to 7 every 7 days. And then we also need to consider the other measures such as hub disinfection and replacement of intravenous tubing. Hub disinfection there's level 1A evidence for that. That's well ingrained within literature, and then tubing should be replaced every 96 hours. Next slide, please. So the transparent semi-permeable polyurethane dressings are also evidence-based. They're important because they permit visual inspection, they require less frequent dressing changes, and they have the same rates of colonization to be consistent with gauze. And I already covered the evidence for chlorhexidine-impregnated sponges, so these are two very important preventive measures to apply in the post-insertion period. It's also important to note that there's unclear efficacy of these chlorhexidine-impregnated sponges for the pediatric population due to the risk of toxicity pertaining to contact dermatitis with an overall incidence of 15%. And then the risk of neurotoxicity in neonates. Next slide, please. Just a quick note on catheter design and handling. We know that, first of all, hub disinfection is important, clearly. That disinfectable needle with closed catheter devices may be more efficacious than open lumen devices because they're disinfectable, though the literature is equivocal there. We do know that contamination of open lumen devices is associated with increased mortality, so DNCCs may be more efficacious, but they must be disinfected, supported by work published in Anesthesia and Analgesia in this last year. We know since 1993 that ethanol of all the agents is the most effective agent for scrubbing the hub and should be utilized. And we also know that the way that we handle these devices can be augmented or improved upon. The current hub disinfection compliance rate of approximately 30%, so this is clearly an area in need of improvement. In one study conducted here at Dartmouth, we have demonstrated that you could actually improve hub disinfection by anesthesia providers dramatically by using a IV pole-based disinfection system that resulted in 9% absolute risk reduction in contamination of the devices and a 6% absolute risk reduction in infections in the 30-day postoperative period, including bloodstream infections. And that was in a randomized controlled clinical trial involving 572 patients. Next slide, please. Additional measures to consider are the timing of tubing replacement. The literature suggests anywhere from 72 to 96 hours, unless you use blood and lipids, where it should be 24 hours. And then daily chlorhexidine body washes is listed as level 2, but actually the evidence for this is stronger than that, in my opinion, in our opinion, because there's a well-designed, controlled crossover study that involved 836 patients in Chicago, where they actually demonstrated that use of 2% chlorhexidine washes as compared to control reduced infections from 10.4 in the control group to 4.1 in the treatment group as compared to soap and water. This is something else that we should also consider. Next slide, please. We also need to consider the choice of the catheter. I'm just going to summarize this slide by saying that using a PICC line is not an easy out. They carry the same infection rate as a temporary catheter. And this also plays into this concern of increasing infection rates outside of the ICU and infections occurring during home-based care. So we need to consider that emerging evidence suggests that these are problem areas for central line-associated infections that are now increasing in prevalence. And we need to consider the factors that I have listed here and work to prevent these infections as well. And Dr. Koff is going to talk about a unique prevention program targeting these areas that we were able to have the pleasure of seeing at Denver Health. Next slide, please. Antiseptic antibiotic-impregnated catheters is an interesting topic. It does reduce infections. It does so dramatically, but because of the risk for fungal infections, specifically Candida, it's only indicated under a certain subset, and that's where you have a patient with persistent infections despite the usual measures, a patient with recurrent infections, or somebody who is, such as a dialysis patient who has difficult vascular access. Next slide, please. Okay, go ahead.
So my name is Matt Koff. I'm going to just continue the discussion here. And this really is a nice slide that kind of summarizes a lot of the results and evidence that Randy, Dr. Loftus had talked about in the previous slides. So the importance of education, training, and staffing. Also, we're going to kind of also describe insertion and removal practices as kind of, these are the larger categories, as well as maintenance. And so under education, training, and staffing, some of the important areas that we need to make sure all our patients are getting are the, again, periodic assessment of knowledge of the providers that are involved with maintenance and insertion of central lines, credentialing, as well providing, making sure the providers who are handling and inserting these lines are credentialed. Also standardizing practices across the facility, and this really allows for kind of the reduction in variability of practice. Also establishing culture of safety, very important, as was described earlier, and we'll talk more about that. Insertion removal practices, you should try to have a systematic approach. Again, only trained personnel demonstrating competence for insertion of central venous lines and peripheral IVs. That is really good evidence supporting that, and we should consider doing that at our facilities. The IHI bundle, clearly that's something we should all be doing, and we have that in the toolkit that you can refer to. As far as adherence to a checklist and documentation, we'll describe that in more detail. And other measures, for example, if you have dialysis patients, these would be considered more high-risk patients. Or if you fail the kind of the standard measures, then you should consider antibiotic-impregnated central lines at that point. So maintenance is also another important category. The frequency of dressing changes, so trying to reduce the frequency of dressing changes and utilizing daily inspection for that. Chlorhexidine for insertion and maintenance, using and also with semi-permeable transparent dressing. And Miriam Dowling at our institution actually came up with a nice video, and that's in the toolkit that you guys can look at later, and I'll talk a little bit more about that later. We've also the split septum catheters that Randy had just talked about as far as being important and potentially an emerging catheter kind of design. We also want to reduce access to catheters. This is kind of a newer way to kind of look at trying to more ahead of the curve, look at reducing, if you reduce access, you can reduce opportunities for errors and contamination. So, and I'll talk more about that later. Next slide, please. And so when we think of kind of what we're doing here with different institutions all trying to achieve really good results in patient safety, we can kind of divide it into the getting started groups, the working harder group, and groups that are ahead of the curve. And interestingly, you know, you think of these as kind of finite areas, but what you may find at your institution is that you may have feet in each of these sections or be right at the getting started section. So, for example, and we'll describe here that we actually are, we'd like to consider ourselves in the working harder to ahead of the curve, but in fact, we have some areas that we really need to improve in the getting started areas. So we're a good example here of kind of having feet in all these areas, and we'll present some other groups that actually have really solid footholds in the working harder and the head of the curve area. So we'll describe that. Next slide, please. So if you're in the getting started group and we want to work on the translating evidence into practice, you really want to identify high-risk areas in need of improvement. This could be, example, the ICU for CLABSIs or the NICU. So you want to look at your own facility and kind of get a sense of where the need is. Then you want to identify and build a team that understands the culture in those areas, and that's very important because that's how you're going to improve care and create change. You want to be able to educate personnel and implement best practice, and best practice, as we mentioned, would be the IHI bundle. And then you want the ability to measure outcomes because that's how you're going to show improvement. Next slide, please. So as far as team building goes, if you're in the getting started group, how do you start the team? It's kind of a difficult concept. What you really need to do is have a kind of overall, you want a clinical practice oversight committee. And this is going to be valuable for all improvement measures. So whether it's, VAP or CAUTI or CLABSI, this is going to be really important. And you want to make sure that that's going to involve senior leadership so that you have high-level folks that can make decisions quickly and can then kind of affect change down below. So beyond the Clinical Practice Oversight Committee, you then want an executive committee, and this would be, an example would be, and you could call it whatever you want, but ideally you want a committee that's going to meet weekly and that could consist of an infection control practitioner, whether that's a nurse or an MD at your institution or both, physician leaders that are skilled in quality improvement and gap analysis, a CMS abstractor for chart review, an administrator if you can, nurse specialist that's important with outcomes, and then a data analyst that can provide you with weekly updates and scorecards. Next slide. And then another example would be to have an intermediate group, and this is really what we would consider your working group. And this working group is responsible for actually implementing change based on the gap analysis that was discovered, organizing and monitoring line insertion and maintenance techniques in applicable arenas, education, rollout, and standardizing practice. We can really look at things in real time, so not in a delayed fashion, and also that they would be able to report defects to the overseeing executive committee. And this would be important folks to have on this team would be the physician and nursing leaders. You want to be able, this committee wants to be able to report back to the executive committee as needed with important changes to be vetted and or with defect analysis. And typically you'd want to look at a monthly meeting kind of agenda schedule. Next slide, please. And so if you're in the getting started group and you want to look at education and implementation, again, we talked about the employee's self-education fact sheet. You want to develop a credentialing and certification process. You can utilize in-service lectures, and again, we have some examples of dressing changes done here for that. And you also want to give periodic updates and reassessment. You want to provide feedback to the group, both at the group and individual level. Next slide, please. So again, you definitely want to be implementing the IHI bundle. And the IHI bundle facilitates compliance with CDC guidelines. It tends to reduce the number of steps required for line insertion. That's what these line cards do in this. And it seems silly, but really the line card does a lot of things for you. If you don't have that, you really need to get that. And there's just a website here where you can, if you need to order a line card, you can, this is one example of many places that would have that. And also what the line card does is it supports an overall culture for safety. It incorporates a checklist for real-time insertion, and it reduces unnecessary contact with the surrounding patient environment as well. And it also empowers other providers to generate a hard stop if you have lack of adherence to the IHI bundle. Next slide, please. And these are some examples. Actually, this is from Denver Health. These are examples of line cards. For example, the one on the left is from the MICU there. The one in the middle is from the SICU. And yes, even in an emergency department, you can have a line card. And that's a very busy, high acuity emergency department. And so it can be done. As an example, you can also adopt these cards so that they fit the culture of your unit. For example, the SICU has, if you look at these kind of red bags at the bottom, they have everything bundled and standardized together. So they actually have the actual line kit, they have the hat, mask, cap, and gown in there, and then the gloves are in another drawer. So you can make these work for your unit and your culture in your unit. There's an inventory that we included on the toolkit as well that you can get later on. Next slide, please. Procedure checklist is very important. The goal of this is really to improve teamwork, and it helps focus efforts on infection and prevention. It also should be completed by another observer who's helping oversee the line insertion, and that's very important because at any point this observer or anyone else in the room could call a stop to the procedure, and if the procedure jeopardizes the patient in any way, a sterile field, you can have the team regroup and start all over. And again, this is important. Everyone has a responsibility to be doing this. Next slide. So how do we measure our success after we start implementing these practices? Well, again, we go back to the definitions. We need to have good definitions that we're using, standardized definitions, and a BSI, basically CLABSI is either a BSI with a central line or clinical sepsis in the presence of a central line with no obvious source. And then you need to be able to calculate your CLABSIs, which is essentially CLABSI divided by central line days times 1,000. Next slide, please. And so we need to be collecting data, because we ultimately within this 10 initiative, we want to show a 40% reduction. And so to do that, we need to establish a baseline. So ideally, if you have data ready, you should be using data from 2010. If you don't have data, try and use data from the last 3 to 6 months or so. And you want to track monthly rates. You want to utilize annotated run charts, and we'll show you some examples of those that track changes made during that time period. And you want to start in pick one high-risk unit in order to track changes easily. You want to follow patients for 48 hours or following the line discontinuation. And you want to consider identifying an infection control officer for tracking these. Next slide, please. So kind of going back to that whole getting started, the whole continuum, this is kind of more or less the Dartmouth experience, where we'll talk a little bit about how we started this way back when, really in 2006 or so. But we just utilized as a data collection tool, we utilized as an access database, and we performed individual audits this way. Next slide. And then we wanted to, looking at process measures, so this is how we would show that we're adhering to our IHI bundle during the insertion. And this is our current version. We had an older version with our prior EMR, and this is our new version on our current EMR. And we're actually having some problems with this, and we'll talk about this a little bit. And these, in our state, in the state of New Hampshire, we're actually we have to report the adherence to this bundle to the state. Next slide. And so we are acquiring this data every month, so we're looking at the green line on top, shows the percent of adherence to the IHI bundle, which is indicated on the left, as we previously mentioned. And also the yellow lines kind of, or the yellow lines kind of indicate the number of lines that are placed in the ICUs, in our ICU over that month period. Next slide. What we were also able, so that's an example of kind of getting started, and now this is an example of kind of being ahead of the curve a little bit. What we tried to do in our institution, based on some of this data that we've been tabulating over the years, we also tried to drill down on some of the important aspects of the IHI bundle, and we felt hand hygiene was going to be an important measure for us to try to go after. And so we tried to implement a multimodal hand hygiene intervention. And because we've been tabulating data for these many years, we were able to show an effect of this multimodal hand hygiene intervention. Next slide, please. And so this is going to be an example of, as you track out throughout the years, you track out your various interventions, and you can kind of see how you've been impacting your rates at your institution. As you can see, we've done certain things in getting started, and other things kind of working harder. And basically what we've shown is we have to go back and redo some of the things getting started. So for example, we did not really we started the central line cards, but we didn't really initiate the bundle well and the checklist well until 2009. And so constantly you may have to go back and look and see where you are and make sure, look at your gap analysis and see how you're doing. Can you go back on the slide, please? Yeah, that one. Again, if you see benchmark on the lower right, clearly the benchmark will continually move throughout, as you're tabulating this. In 2006, clearly the benchmark was not 1.5, but we're at that point right now. Next slide, please. And this is another way. A process control chart's really nice in that it can help you figure out where you are. You're going to have variability, and the variability is indicated by the data in the dotted lines. But you'll also notice in a gray line, you can actually see what the mean is, and this is the NHSA mean, which is 1.08. And then you have the dotted line way up top, which indicates if you're kind of out of bounds. And so that's what we find the process control chart to be very helpful with. It can really help you identify if you're way out of bounds, which would be 2 standard deviations beyond the mean. Next slide, please. So working harder, if you look at our gap analysis, and we kind of took a look at what we were doing, and we are still at the point where, you know, we have not established a true culture of patient safety here. And so that's something that we need to work on, and we recently started to have a more top-down control here in the hospital infection committee here, and so that's going to be really important. And so to have that top-down support, again, you need that. As far as data analysis, you need to have a good ability to understand where your defects are, and that's how you're going to implement change based on those. So you want to make sure that you're measuring compliance. At our institution, we're having trouble measuring compliance with the IHI bundle, and it's really because of how it's inputted onto our new EMR, which is awkward, and we're having a lot of inputting errors with folks at our institution, and so that needs to be fixed. As far as maintenance, it's important to have good education, and we've done some dressing changes video. Miriam Dowling has done that here. And also we want to look at proper handling of all intravascular devices, and we've implemented a dressing change kit throughout the ICU. And also the scrub the hub, that's an important area that we need to improve on, as do many areas need to improve on. Next slide, please. This is just an example where you can look at kind of audits as far as your intact dressings, and you can follow those over time, and you can actually look at sites and drill down on potential areas of problems. Next slide, please. And so if you look at examples of working harder, Denver Health is, it was highly effective as a team building, with team building and structure throughout their healthcare system. They had amazing top-down support, and they're highly effective, again, with defect analysis. They're excellent at standardizing equipment across multiple units, utilizing the least expensive options. And they're really innovative with teams. For example, there are PIC teams that can go around the wards and insert them. They use also alternative intravascular devices, such as the Hone catheter, and for dressing maintenance and tracking of patients. And so they're really a good example of that. Next slide, please. Being ahead of the curve, the Mayo experience, we found them to be kind of ahead of the curve with regard to they're expanding this process throughout their hospital and throughout their institution through, you know, not just the adult ICU, as many institutions are doing. And they also enhance maintenance factors. So they're looking at preventing, you know, infection during maintenance. So they want to limit access to these catheters and kind of bundle lab draws so that people aren't drawing and accessing these catheters all the time. They're also encouraging IV to PO conversion, so avoiding the administration of medicines that, you know, continually re-access these catheters. And then they also they're looking to improve compliance with hub disinfection as well. Also, we look at ahead of the curve, things that we've been trying to look at here is a better understanding of bacterial cross-contamination leading to device contamination in the hospital environment. And so we want to look at specific bacterial contaminants, modes of transmission, rates of transmission, and also involvement of very specific strains in the healthcare setting. Next slide, please. And so we've included some Toolkit resources, and we've added some things, some videos from our institution here, and we found that really that the Stop BSI website, next slide, has an amazing toolkit there, and they have toolkits from the NICU as well as the adult ICU, and a lot of good resources there that they've done an amazing job with tabulating and keeping all in one place. Also, AHRQ has some nice CUSP resources to help look for resources on that, the toolkit for there. And we have some videos, again, on looking at changing central line dressings. I think for that, we're done with our slides. We have some references at the end, and if there are any questions, happy to entertain any questions.
If there are any questions, you're welcome to insert those on the chat box on your WebEx browser. We are at the hour mark as well, so we understand that many people may need to get off. You can also email the questions to us at admin@henlearner.org, and we can field those to Dr. Koff and Dr. Loftus as they come to us. Thank you for your time, and thank you, Randy and Matt, for your presentation. It was fantastic. We will have a recorded version of this up on the HenLearner website in the next couple of days, so you can check back. It'll be under the resource tab. Thank you.
Thank you.